Hi everybody, welcome to this session on NEET-PG 2023 Recall Anatomy. Hope you have given your best test, right? So as far as anatomy is concerned, ADrPlexus has given you 100% conceptual learning, which must have given you the courage to face all the questions with much more confidence, right? So around 17 questions have been from anatomy, yes, integrated with the clinical subjects. But yes, if you have had your anatomy thorough, you would have easily answered it all, right? So we'll go into the session straight now and then analyze it at the end. So this was an image-based question from embryology, right? And the arrow was pointed at this structure and question like remnant of the pointed structure, what will it become in adult? Yes. So these were the options given. Yeah. And what is the answer? What is the pointed structure? It's the allantois, right? So the allantois in the adult life, it obliterates to form the urachus. And the urachus, yes, it forms the median umbilical ligament. It is a repeat question and very important question. We'll just see few points related to it, okay? So remember, there are the two sacs, the amniotic sac and the, yes, yolk sac. Yeah, I'll show it as a green color, the endoderm of the yolk sac. Around day 16, it forms a small outpouching called as the allantois. You know exactly where? In the region of the connecting stalk. Okay. Now, what is happening during the folding of the embryo, which is shown in the image asked? Yes. So the endoderm of the yolk sac is going to get incorporated into the embryo as the gut tube. And in the region of the umbilical cord, the endodermal gut tube is going to be connected to the remnant of the yolk sac through the vitellointestinal duct. And what happens to the allantois now? Yes. So the allantois, yes, which is also at the connective, like the connecting stalk or the umbilical region. Yeah. So that also opens into the gut tube. Which part of the gut tube? The hind gut. Right. So if I'm going to draw a picture of this, so this will be the hind gut and that's the allantois opening into it, right? Now, this part of the hind gut below the opening of the allantois is going to be called as cloaca. Now, what's going to happen in the cloaca? Yes, the urorectal septum, it comes and divides it into an anterior part and posterior part. The anterior part of it is going to be called as primitive urogenital sinus. And the one which lies behind the urorectal septum, that's going to be called as the primitive rectum. Now is the interesting part. So this allantois, yes, opening into the primitive urogenital sinus, right? Now the mesonephric duct comes and opens it here. Where? Into the primitive urogenital sinus. So this part of it, about the opening of the mesonephric duct, yes, that's called as the vesico-urethral canal. And the lower part is called as the definite urogenital sinus. So this vesico-urethral canal is going to give rise to the urinary bladder. And where is the allantois opening now into? The cranial part of the vesico-urethral canal or the urinary bladder. And as you see here in the midline, from the apex of the bladder to the umbilicus, this is the median umbilical ligament, which is a remnant of, the obliterated part of the urachus or the allantois. Got it? Yes? Yeah. And if you want to add, right, this is the inner wall like of the anterior abdominal wall. Yes. So this is the lateral umbilical fold, which has the obliterated umbilical vessels. And this is the, this is the median umbilical fold. This is medial umbilical fold, which has the obliterated umbilical vessels. And this is the lateral umbilical fold, which has the inferior epigastric vessels, right? So this is a very, very, very important topic, and repeatedly they have been asking questions over this part, which you have to be definitely thorough. And of course, it has been covered in your, yes, your 6 a.m. image-based question, as well as also in the workbook, right? So we remember we saw if the allantois is going to be completely patent, that will form a urachal fistula. If only the distal part of it is going to be patent, that will form the urachal sinus. Intermediate part is patent, urachal cyst. So remember, in the morning 6 a.m. session, image-based question session, we got to see a case scenario, and we also went through the repeated questions in which this portion has been covered for you. Hope you got it right. The second question, which is also a repeat one, yeah, an image-based question, where they have asked to identify the defect is in which structure. And yeah, which one was given? Whatever be the image, you would have seen a communication between the aorta and the pulmonary trunk, right? Which is not a normal one. As you see here, so this is the patent ductus arteriosus. Yes, as you see in all these images. Now, what is this defect due to? The right or the left or the fourth or the sixth arch artery? Yes, we'll quickly go through it. Okay, remember, there are how many arches? Totally 6, isn't it? Of which are the ones that disappear? 1, 2, and 5. What are the ones that remain? 3, 4, and 6. Of the 3, 4, and 6, as you see here, this is the third one, the fourth one, and sixth one. What is this? This is the seventh cervical intersegmental artery that's going to give rise to the artery of the upper limb. And what is this? This is the dorsal aorta, which is going to give rise to the descending aorta. Now, what happens? This is the truncus arteriosus, the ventral part of it, which receives the third and the fourth arch arteries. This is the dorsal part of the truncus arteriosus, which receives the sixth arch artery. Okay. Now, I'll give different colors for each artery. What happens to the third arch artery? Yes, it will give rise to the common carotid, the external carotid, and the internal carotid. Okay, common carotid artery, external carotid artery, part of the cranial part of dorsal aorta, internal carotid artery. What happens to the fourth arch artery? So the ventral part of the aortic sac, the left horn of the aortic sac, the fourth arch artery, and part of the dorsal aorta on the left will give rise to arch of aorta, the left fourth arch. Now coming to our point of discussion. Yes, I'll take it a different color. So the sixth arch artery is going to give rise to the pulmonary artery. Now, this pulmonary artery, yes, it is connected on the left side alone to the aorta, descending aorta. This part of the sixth arch artery, it remains patent to form the ductus arteriosus. Whereas on the right side, it disappears along with the dorsal aorta, isn't it? So this ductus arteriosus, when it is supposed to close? Soon after birth, right? The functional closure of ductus arteriosus occurs immediately after birth. And the anatomical closure occurs around 12 weeks, isn't it? Okay. So this is the ductus arteriosus. Okay. Due to persistent ductus arteriosus is due to, yes, persistent part of the left sixth arch artery. And what happens there? Left to right shunt. Am I right? Okay. So this was covered again in a 6 a.m. image-based question embryology session in ADrPlexus. And as well as in your workbook, you would have written it right. Got it right? Now coming to the third question, a case scenario. Yes. So a student yawning in the afternoon class and got stuck with open mouth. So which of the following muscle is attached to the articular surface of mandible? Okay, the temporomandibular joint and the muscle responsible for this condition. Okay, Yes, it was covered in a 6 a.m. IBQ session. Okay. Now, let's see the temporomandibular joint. You can see the condyle of the mandible, which is going to articulate with the glenoid fossa of the temporal bone to form the temporomandibular joint. Can you appreciate the capsule here? This is the capsule of the temporomandibular joint. And something you see within, yeah, I'll take a different color. Okay. So this is the intra-articular disc of the temporomandibular joint. Okay. Now, what is this muscle here, which has two heads, upper head and lower head? The muscle, right? Upper head and lower head. The upper head of this muscle you can see coming from the greater wing of sphenoid, and the lower head is going to come from the lateral surface of the lateral pterygoid plate. This is the lateral pterygoid muscle. Okay, so the lateral pterygoid muscle is the one which is going to insert into the, not only into the capsule, also into the intra-articular disc of the temporomandibular joint. Right. Now, what is this muscle going to do? The contraction of this muscle will depress the mandible, will pull your mandible down. And of the four muscles of mastication, what are the four muscles of mastication? Lateral pterygoid, medial pterygoid that you see here, temporalis and masseter, right? Of the four muscles of mastication, yes, only lateral pterygoid is the one which is going to depress the mandible and open the mouth. So normally, as you see here, this is the head of the mandible, which is received by the glenoid fossa, the condylar fossa of the temporal bone to form the temporomandibular joint. What happens when you wide open your mouth as you yawn? Okay, this can dislocate. The most common dislocation is anterior dislocation. Okay, a cranial dislocation and posterior dislocation can happen, but the most commonest is anterior dislocation, where from the glenoid fossa, it's going to come forward and it gets stuck onto these articular eminence that you see here. Okay, that's why you're not able to close it again, put it back into position. Okay, so this anterior dislocation, as you see here, you can see it here in the X-ray also. Yes, and the muscle responsible and attached to the capsule and the intra-articular disc is lateral pterygoid. Yes, was this concept taught in ADrPlexus? Of course, it was given in our classes, as well as also you'd have written it in your workbook, right? Got it right? Yes. Coming to the next question, it was an image-based question. Yes. So what was there? A parotid swelling, and they've asked you the pain in this parotid swelling, the anatomical reason for it. Okay. And I got a wide variety of options, and I wonder whether this option was given. So what is responsible for pain? Yes. So some nerve, right? A sensory nerve which is going to supply the skin over that. You know that the sensory innervation to the face is by the fifth nerve, the trigeminal nerve. Ophthalmic division, maxillary division, and mandibular division is going it's going to innervate the skin over the face, except the area over the angle of the mandible and the skin over the parotid is going to be innervated by the great auricular nerve, right? Okay, but there was another option given, right? Yes, what was that? The deep cervical fascia. You know that the deep cervical fascia has three layers. What are they? The investing layer of the deep cervical fascia, the pretracheal fascia, and the prevertebral fascia. What is this investing layer of the deep cervical fascia going to do? So imagine this is the parotid gland. Now this investing layer is going to divide into a superficial layer and a deep layer. It splits to enclose this gland. Okay, the superficial layer will be attached to the zygomatic arch, and the deep layer is going to attach to the styloid process. Now, this superficial layer, yes, it's going to be given a name called as the parotidomasseteric fascia. Okay, what is special about this fascia? Yes, you remember the facial muscles are remnants of panicles carnosus. They are present immediately beneath the skin and there's no deep fascia over the face. Am I right? But except in the region of the parotid gland, you have this parotidomesenteric fascia, which is clinically important, which comes under the superficial musculo-upper system. Okay. So why am I talking about this now? This fascia is very tough. Okay, the exact word that has been given in our Gray's Anatomy also, unyielding nature of the parotidomesenteric fascia, the investing layer of the deep cervical fascia, okay, is responsible for the pain in case of parotid swelling. Okay, so here, yeah, yes, I will underline it for you. Yeah, stretching of the capsule and stimulation of the great auricular nerve. So even Grace has mentioned stretching of the parotid capsule, that is the investing layer of the deep cervical fascia or the parotidomesenteric fascia, as the first cause of pain in case of a parotid swelling. And then comes the great auricular nerve. So in case, if the deep cervical fascia was not given, it is right for you to go with great auricular nerve. But if both the option is given, then the first preference, yes, with reference from Gray's Anatomy is deep cervical fascia. Okay. Yes. So this was also taught in our parotid gland. Hope you have written in your workbook also. Yes. Got it right. We'll move on to the next question. Tonsillitis, the pain, the referred pain to ear is due to which nerve, right? So fifth nerve, as I told you, innervation over the face, right? Ophthalmic, maxillary and mandibular division. Seventh nerve is entirely motor except for its supply over the skin of the concha through its communications with the vagus nerve, right? And the vagus nerve has only one cutaneous branch. You must have learned it, Alderman's nerve, yes, which supplies the concha, and this has communication with the seventh nerve. Now, the tympanic branch of the ninth nerve is the option. Okay, we'll just see few words about it. So this is a palatine tonsil. Where is it situated? In the lateral wall of oropharynx, isn't it? The structures which form the tonsillar bed, do you remember? Yes, we have the connective tissue with the paratonsillar vein, and then we'll have the pharyngobasilar fascia, the buccopharyngeal fascia, and the muscle sandwich between these are the constrictor, the superior constrictor muscles. So this glossopharyngeal nerve, it lies in the lateral wall, the tonsillar bed. This glossopharyngeal nerve, it supplies not only the palatine tonsil, it also supplies the soft palate above. The ninth nerve supplies the posterior 1/3 of the tongue. It also goes behind to supply the oropharyngeal isthmus. Now, in Gray's Anatomy, right, they have given a nice concept telling that, okay, here. What were we talking about? The ninth nerve. So, the ninth nerve, along with the lesser palatine branches from the maxillary nerve, okay, or from the pterygopalatine, which passes through the pterygopalatine ganglion uninterrupted. They form a plexus around the palatine tonsil called the sulcus tonsillaris. Okay, okay, that's fine. Now, this ninth nerve will give a tympanic branch that is going to enter the middle ear through its floor. Okay, the bulb of the jugular fossa, which lodges the superior bulb of the internal jugular vein. Through the floor, it enters the middle ear, and over the medial wall of the middle ear, you have the basal turn of the cochlea producing the promontory, and over that, it forms a plexus, the tympanic plexus. This tympanic plexus is going to supply the mucosa of the middle ear cavity. So any pain in tonsil, okay, any tumor, any pain, any infection, or even tonsillectomy procedure, the pain that is referred to the ear is because of the tympanic branch of glossopharyngeal nerve, which is also called the Jacobson's nerve. Yes. So this was, of course, taught in your classes and it's there. Yeah, you have written it in your workbook also. Yes, guys? Yeah. So this was an image-based question of the nasopharynx and exactly what was pointed. Yes, you have to tell me. I'll give you the explanation. So we'll see this first. Okay. So this is the your palate, right? Above that you get to see the nasal cavity. You can see the concha, inferior nasal concha, middle concha, superior concha. So this is the lateral wall of nose. Now our area of interest here is, yes, you see the opening of the eustachian tube. Where exactly? 1.25 centimeter behind and a little below the posterior end of inferior nasal concha. Okay, this opening, Grace explains it very beautifully. It is triangular in shape. I'll do the same thing here, okay? Yeah, endoscopic view. This slit, it's not a perfect oval or circular, it's triangular in shape. And from that eustachian tube opening, you get to see two mucosal folds. One is larger, going downwards towards the pharynx, and one is small, going towards the soft palate. So if you want to orient to this picture, you see the septum here. So this should be medial, this is lateral, and this is the area of your soft palate, floor. Okay. Now this one going downwards, yeah, towards the pharynx, that's the salpingopharyngeal fold, which lodges the salpingopharyngeus muscle of the pharynx. And this smaller fold, right, going towards the soft palate, down, yes, that's the salpingopalatine fold. There's one more thing. See, in the floor, just below the eustachian tube opening, in the floor, you see another fold that's produced by the levator palatini. Where is this levator palatini going? Towards insertion into the soft palate. Levator palatini fold. Okay. Now, this elevation that you see produced by the cartilaginous part of the eustachian tube opening. Okay. That is called as the torus tubarius. Yes. And the lymphatic tissue that you see over here will be called as the tubal tonsil, which is part of the Walder's ring. Am I right? And a deep recess, okay, that lies behind it will be the fossa of the Rosenmuller. Now you understood the structure. So the where was the arrow put? Whether in the eustachian tube opening, that is a slit-like orifice, or whether on the elevation above, that's the torus tubarius, or posteriorly into the recess, the fossa of Rosenmuller. Where was the arrow exactly? Yes. So you must be knowing the answer, right? Yeah. So the Gray's Anatomy, the description is given very, very nicely. Okay. And while talking about in classes as well as in workbook also, we have given you the features of the nasopharynx, right? Hope you got it right. Yeah. So this was a question in lower limb, an image-based question where ABCD was marked right. And yes, the question was something similar. The damage or fracture to which of the following structure will cause dorsiflexion of foot? So this is X-ray of the knee joint, and you see the femur above, the tibia here, and the fibula. So what was exactly marked? This could be the medial condyle of femur, the lateral condyle of femur, medial condyle of tibia, lateral condyle of tibia. This is the head of the fibula. This narrow portion is the neck of the fibula. Okay, and what is clinically important here, which must have been taught repeatedly in your ADrPlexus classes and given in your workbook also, and repeat NEET-PG question. The nerve winding around the neck of fibula. What is it? Yes, the nerve winding around the neck of the fibula is the common peroneal nerve. So the upper angle of the popliteal fossa, the sciatic nerve is going to divide into tibial nerve, which runs in the posterior compartment of the leg. And then the common peroneal nerve that winds around the neck of fibula. It's going to divide into two, right? Yes, tell me, what are the two divisions of the common peroneal nerve? It's going to divide into superficial peroneal nerve and the deep peroneal nerve. The superficial peroneal nerve, it continues into the lateral compartment of the leg to supply what muscles? In the lateral compartment of the leg, we have the peroneus longus, peroneus brevis. And what are they going to do? These are the everters of the foot. Am I right? And what is going to the deep peroneal nerve? This deep peroneal nerve, it continues into anterior compartment of the leg. Am I right? In the anterior compartment of the leg, these muscles are going to cause dorsiflexion. Yes. So the answer here will be the winding around the neck of the fibula. What was it labeled? Okay. So this is just a picture to show you the common peroneal nerve winding around the neck of the fibula. A repeat NEET-PG question, clinical question. For you to identify the muscles in the anterior compartment of the leg. This one is tibialis anterior. Immediately next to it, right? This one that you see here, extensor hallucis longus. And this one, the tendon that you see here, is going to divide into 4. This will be the extensor digitorum longus. And this fleshy muscle fiber that you see here will be the peroneus tertius. Okay. So what is the action of all these muscles? All of them are going to cross your ankle joint and go to the dorsum of the foot, and it will elevate, right? The dorsiflexion of the foot. What will happen if this nerve is injured? These muscles will go for paralysis. The patient will not be able to elevate, dorsiflex the foot, and the foot goes for drop, right? So injury to common peroneal nerve, we have been teaching repeatedly, foot drop. Winding around the neck of fibula. So it was given in your classes. It was also covered in the rapid revision right before your exams and also in your workbook. Hope you got it right. Okay. This is another question. Yeah, this is also interesting. Laparoscopic hernia repair. The nerve entrapped in the fixators and the patient presents with history of pain for 3 months and the pain radiating to the lower limb after surgery. Yes. So if you remember, yeah, laparoscopic hernia repair, the 2 important triangles will be the triangle of doom and pain, isn't it? Triangle of doom and pain. What is the structure common to both these triangles? You have the spermatic vessels, right? Yeah. So the spermatic vessels will be the here medially you'll have the vast difference for the triangle of doom, laterally spermatic vessels. For the triangle of pain, spermatic vessels will be medial and the iliopubic tract will be lateral. Why is it called triangle of doom? What is the content there? The external iliac vessels, am I right? The external iliac vessels are present in the triangle of doom, and an accidental injury to it, yes, it can lead to severe bleeding, right? And what about the triangle of pain? Why is it called triangle of pain? There are a lot of nerves running it. What are the nerves there? The femoral nerve itself, yes, femoral nerve, the femoral branch of genitofemoral nerve, the anterior femoral cutaneous nerve of thigh, and more laterally, we have the lateral cutaneous nerve of thigh. Okay. So the common nerve injured in a laparoscopic hernia repair is lateral cutaneous nerve of thigh. Okay. This is also a topic of interest which has been asked repeatedly over the past few years. Yeah. So pain along the lateral aspect of the thigh. You can see it here. So this is the triangle of pain here and the triangle of the doom with the external iliac vessels. In the triangle of pain, can you see a bunch of nerves as I told you? What did I tell you? The femoral nerve, femoral branch of genitofemoral nerve, anterior femoral cutaneous nerve of thigh, and lateral most will be the lateral cutaneous nerve of thigh. Okay, with the root value L2, L3, pain radiating along the lateral aspect of the thigh, meralgia paresthetica, remember? Okay, so yeah, we have taught this for you in the class and it is also given in the workbook. Okay, hope you went through it and got it right. This was another interesting question. Yes, easy. And yeah, it was a sort of an indirect question, but very interesting question. Complication of rectal surgery after ligating the main trunk. Okay, what could be the complication? Yes, So I'll just give an explanation here. This is the sacrum. You know, the sacrum is a triangular bone. You have the lumbar vertebra above. Okay. What is the level of bifurcation of the abdominal aorta? L4, isn't it? Now, below the bifurcation of the aorta, okay, opposite lower lumbar vertebra or in front of the sacral promontory, you get to see a plexus. Any idea what is this plexus called? The presacral plexus or the superior hypogastric plexus. From this plexus, two nerves will come down. They are called as the right and left hypogastric nerves. Now, where is the rectum? Lying in front of the sacrum, right? So, this is a rectum anal canal. Okay. Now, what is the relation of this plexus to the rectum? Posteriorly and posterolaterally. Okay. So, here, the inferior mesenteric artery is going to continue as the superior rectal artery. When you're going to do a high ligation of the inferior mesenteric artery, superior rectal artery, and complication can come from injury to this presacral plexus. Why are we talking about it now? This presacral plexus or the superior hypogastric plexus and the right and left hypogastric nerves coming from it are purely sympathetic. Okay? And the two important phenomena in a male, yes, erection, ejaculation, of which erection is, yes, by the parasympathetic. Am I right? What is the nerve responsible? The pelvic splanchnic nerves. From which spinal cord segments? S2, S3, S4. What are these pelvic splanchnic nerves going to do? The parasympathetic fibers passing through it will cause dilatation of the arterioles that supply the corpora cavernosa and fill the cavernosa with blood and impede venous return. So that goes for a erection. Okay. And what is ejaculation? Ejaculation, remember, it is a sympathetic phenomenon. So what is going to happen during ejaculation? The sperm that's produced from the testes traversing the epididymis, yes, has to pass through the, I'll take a different color. Yeah. So you have the vas deferens, the seminal vesicle, and they have the ejaculatory duct. The ejaculatory duct is going to open into the prostatic urethra, right? Into the prostatic urethra. Okay, into the prostatic urethra. And above the prostate, what do you have? The bladder. The lowermost part of the bladder, yes, you get to see the trigone of the bladder. Okay, the apex of the trigone will receive the ureter. Am I right? Now, what is the sympathetic going to do? It is going to cause contraction of the vas deferens, of the seminal vesicle, ejaculatory duct, contraction to expel the semen into the prostatic urethra, right? The seminal fluid with the semen is reaching the prostatic urethra. Now, the important phenomena that's going to happen once it enters the prostatic urethra, it should travel into the rest of the urethra, right? The membrane is the penile urethra and not go back into the urinary bladder, right? So the internal urethral orifice that you see here at the junction of the urinary bladder and the prostatic urethra opening, internal urethral orifice. Okay. Its constriction is produced by the sympathetic fibers. Understood? Now, what will happen during rectal surgery? Yes, during high ligation of inferior mesenteric artery, there is possible chance of injury to the presacral plexus, the hypogastric nerves, which are sympathetic. Okay, so the constriction or the sphincteric action of internal urethral orifice can be lost, and in that case, there will be retrograde ejaculation. Got it right? Okay, this concept, you must have understood it from the posterior relations of rectum, which must have been discussed in the ADR classes, right? Next, another important question, a repeated and easy question. photosystemic anastomotic site in cirrhosis, or it was like put like which veins form the large visible anastomosis in portal hypertension? Yes. So you'll tell me, how is the portal vein formed? The splenic vein. Yeah, it unites with the superior mesenteric vein to form the portal vein. That will divide into a right and left branch, right? Now, at the lower end of esophagus, what happens? The left gastric vein, which is the tributary of the trunk of the portal vein, yes, it communicates with which tributary of IVC? What is there in the lower part of the thorax? The inferior hemiazygos vein or the accessory hemiazygos vein? Yes, that's the systemic tributary. And the portal tributary is the left gastric vein. Yes. So what happens in portal hypertension? And the pressure increases. Yeah, these collaterals, they become enlarged and lead to varices, which can rupture, causing hematemesis. Am I right? So this is the commonest and highly visible one. Okay. The other thing is, the inferior mesenteric vein, which opens into the splenic vein, is actually continuation of the superior rectal vein, right? Yeah, superior rectal vein. The superior rectal vein is formed by the union of the portals, the radicals of the superior rectal vein in the upper part of the anal canal, yeah, above the pectinate line. They all unite to form the superior rectal vein that continues as the inferior mesenteric vein that opens into the splenic vein. Now, this superior rectal vein will have communication with the middle rectal vein, inferior rectal vein, which are going to open into the IVC, right? So there's another side. Yeah, what will happen in portal hypertension? These radicals of the superior rectal vein will dilate and lead to internal hemorrhoids. But the one which is very commonest and the most visible anastomosis is the esophageal varices. Got it right? Okay. Of course, it's a very important topic. It was taught repeatedly, right? Okay. Direct inguinal hernia, it occurs due to defect in which of the following structures? Or it was put like the hernia above the pubic tubercle is due to defect in which of the following? Okay. Now we can talk a lot about inguinal hernias and types, but I'll go with the option wise. Okay. So here what is mentioned is like a inguinal ligament, its extensions and fascia transversalis. Okay. So yeah, we'll go with the options for the explanation. As you see here, what is inguinal ligament? The inguinal ligament is the thickened lower border of external oblique upper neurosis. Isn't it right? Okay, so that extends from the pubic tubercle to anterosuperior iliac spine. Am I right? So this is the inguinal ligament. Okay. I'll show it as a green color, pubic tubercle to anterosuperior iliac spine. Now, from the medial end of this inguinal ligament, 3 extensions are going to come. Okay. So, from the pubic tubercle, some of the fibers, they run backwards, upwards to insert into medial part of pecten pubis. Yes, this triangular ligament is lacunar ligament. This lacunar ligament, it forms the floor and its medial margin, the concave part of it, it forms the medial wall for the femoral ring. Do you remember? Okay. And the next extension, some of the fibers from this, okay, it continues upwards to insert into the pectineal line up to the iliopubic eminence, and we are going to call it as the pectineal ligament of Hooper. Okay. And the third interesting one, okay, yeah, this some of the fibers, okay, it's seen here, it is reflected upwards for insertion into the linea alba, upwards medially into the linea alba. These fibers, we are going to call it as the reflected part of inguinal ligament. Now coming to the most important one, you would have seen an option called conjoint tendon. Do you know what is its other name? The conjoint tendon is also called as fox inguinalis. What is this conjoint tendon going to do, or how is it formed? You can see these are the fibers of transverse abdominis arching over, forming the roof of the inguinal canal. So 2/3 of the conjoint tendon is formed by the inguinal fibers of transverse abdominis and 1/3 by the internal oblique aponeurosis. Now this is going to come and insert into the pubic tubercle, pubic symphysis. And what is its relation? It is going to form the, yes, posterior wall of the inguinal canal, medial half. The medial half of the posterior wall, which is already weak, right? We have the fascia transversalis, and in front of that, we have the medial half is formed by the conjoint tendon. And over the conjoint tendon, the reflected part of the inguinal ligaments. So this strengthens the posterior part of the posterior wall of the inguinal canal. So direct inguinal hernia, it occurs due to weakness of the abdominal wall muscles or through a defect called the Hasselbalch's triangle. But as per the options given, the best choice to go about it will be the conjoint tendon, which lies in the posterior wall, medial half, behind the reflected part of inguinal ligament. Okay. So yes, we have talked about it in our classes. You would have written it in the workbook also. Got it right? Okay. This was a direct question, right? An image-based question with the deep inguinal ring given and asked what is the defect due to. Okay. So easy. Hope you got it right. We'll discuss few points about it because it's a repeat and interesting, important one. So what do you get to see here? Yes. So what are the layer muscles that are external oblique, internal oblique, transverse abdominalis, and anterior abdominal wall? And inner aspect of the transverse abdominalis, you get to see the fascia transversalis, isn't it? Okay. Now, what is mid-inguinal point? Heard about it? Mid-inguinal point is the midpoint between pubic symphysis and anterosuperior iliac spine. Okay, 1.25 centimeter above the mid-inguinal point and opening in the fascia transversalis, you get to see that's the deep inguinal ring, which is oval. Okay, so it's here. This is the deep inguinal ring. And what do you see coming out of it? Yes, that's the spermatic cord in male or the round ligament in the female. This deep inguinal ring, it forms the inlet for the inguinal canal. So the spermatic cord or the round ligament, it enters the inguinal canal through the deep inguinal ring. And from the margins of the deep inguinal ring, you get the internal spermatic fascia that covers the spermatic cord. All these are important MCQs, okay? So all these you should know in relation to the deep inguinal ring, right? Yes. Yeah, of course, hope you have, it has been taught in the classes, you would have written in the workbook and asked repeatedly also. Now coming to the next question, sensory loss over the palmar aspect of the lateral 3.5 fingers, okay? So palmar aspect, lateral 3.5 fingers. The thumb, the index finger and the middle finger and the lateral half of your ring finger. What is the nerve supply? Yes. So this again a repeat question, isn't it? This is a very, very topic of interest, right? A very important topic. So many questions can be asked over it. So lateral 3.5 fingers is by median nerve. Okay. Yeah, they haven't included this area. Do you remember? Yes. That's interesting. Why they haven't included this area over, that is the skin over the lateral part of the palmar surface of the hand? Because, yes, median nerve passes through the carpal tunnel. But the palmar cutaneous branch of the median nerve that's going to innervate this area, it passes above the flexor retinaculum, isn't it? Okay. So the answer is median nerve, and it was not sort of a direct question, right? But it was put as carpal tunnel syndrome, which you must be knowing is because of median nerve compression. Yes. And you should also be knowing that the Durkan's test is for specific for, yes, carpal tunnel syndrome, median nerve compression in carpal tunnel syndrome. Of course, it was like before your exams, we had NEET-PG rapid revision, right? So yeah, we discussed the peripheral nerves. Remember the slide? Okay. So the mode of injury in case of median nerve, remember I told you, what is this? Supracondylar fracture of humerus. Yeah. Entrapment of the median nerve between the two heads of pronator teres. Suicidal cut at the wrist and carpal tunnel syndrome. Okay, so you should be knowing, yeah, with the option and with the picture given, the case mentioned, it is the involvement of the median nerve. And remember, we went through all this, yeah. So this is the hand of benediction, yes, due to injury to the flexor digitorum profundus tendon. And this is the pen test for the median nerve to test which muscle, abductor pollicis brevis. Again, this is the pointing index, yes, where you're not able to flex the distal phalanx of the index finger due to injury to flexor digitorum profundus. Ape thumb due to paralysis of opponent pollicis muscle. Yeah, you can see the atrophy of the thenar eminence because of all the thenar muscles going to be supplied by the median nerve. Yeah, we talked in detail about median nerve injury and the test for signs for median nerve injury. And we also saw this, right? These are the tests which are diagnostic for median nerve compression and carpal tunnel syndrome. So when you perform these tests, what happens? You're compressing the median nerve within the carpal tunnel and the patient will experience paresthesia, numbness, tingling in the area of median nerve distribution. Okay, very specific for carpal tunnel syndrome, median nerve compression. And as I told you, remember, so this is your flexor retinaculum, the structure which passes above the flexor retinaculum, as you see here, the palmar cutaneous branch, it passes above the flexor retinaculum, whereas the median nerve below the flexor retinaculum getting compressed, leading to carpal tunnel syndrome. The palmar cutaneous branch which escapes in carpal tunnel syndrome, hence there is no sensory loss over the skin of the thenar eminence. Got it right? Okay, it's very important. Hope you remember it. We have discussed it in class as well as you must have written it in your workbook. Yeah. So yes, all of you have given like a cock-up splint image was given and the nerve injured. It's typically, classically the radial nerve. Yeah. Hope all of you got it right. So why is this splint? Yeah. To immobilize your wrist and hand. But why? So which is normal and abnormal here? You can see the normal hand. This is the abnormal, yeah, deformity one. So what is there in the normal side? The patient is able to, yes, he is able to lift his wrist or he is able to extend the wrist. Am I right? So what is here on the abnormal one? There is the drop of the wrist, not able to lift his wrist, isn't it? He's not able to dorsiflex or extend his wrist. This isn't flexed. Okay, there's a wrist drop and see his fingers, all his fingers. There's also drop of his fingers. So here you couldn't see the thumb. That's why I put another picture. There is also thumb drop. Wrist drop. Yes, wrist drop, finger drop, thumb drop, which is characteristic of radial nerve injury. Yes. So to put it back in position, to immobilize it, that's why they put this cock-up splint. Okay. Now what is the problem here? Okay. So what are the muscles which cause, yeah, inability to extend the wrist drop or the fingers and the thumb? So I'll put it other way, extension of the wrist. What are the muscles causing extension of the wrist? Come on, tell me. Extensa carpi radialis brevis, extensa carpi radialis longus, extensa carpi ulnaris. All of them going to be supplied by radial nerve. What are the extensors of the fingers or the extensors of the metacarpophalangeal joint? This is the metacarpophalangeal joint, right? You're not able to extend it, right? Yes, that is the extensor digitorum muscle. Yeah, the extensor digitorum. The extension of the thumb at its interphalangeal joint is produced by extensor pollicis longus. Now, all these are going to be innervated by the radial nerve. One very specific thing that you should remember is the extension of the interphalangeal joint of the fingers. That is, yeah, it's not affected, right? They're not going for clawing. They're kept extended. The proximal and the distal interphalangeal joint of the digits. Yes, not the thumb, the other digits, right? Yes, it's remaining extended. Okay. Why? Because the extension of the interphalangeal joint is caused by the interossei and the lumbrical muscles that are going to insert as wing tendons into the extensor digitorum expansion, right? Extensor or the dorsal digital expansion, the interossei or the proximal wing tendons and the lumbrical are the distal wing tendons. So the extension of the interphalangeal joint is not lost in radial nerve injury. Okay. So the cock-up splint for radial nerve injury to prevent all these drops, wrist drop, finger drop and thumb drop. Done. Of course, it was covered in our rapid revision. You must have written it in your workbook also, right? Okay. Easy. Neuroanatomy question was literally easy this time. So a patient sustained an injury. Particle got stuck in the dorsal cord in the neck region. What will be the loss or the transaction of the spinal cord on the dorsal column? And here the hint is only the lateral part is injured. So the dorsal column pathway, lateral part is injured. We know that the dorsal column is sensory. Yes, it's going to carry sensation from the ipsilateral side. Yes. What are the sensations carried by it? Discriminative touch. Discriminative touch. Yes. 2-point discrimination. Right. And then proprioception. And more importantly, stereognosis. Isn't it? Okay. Now coming to the question here, whether it is the arm or the leg. Okay. So you know the dorsal column has two components, fasciculus gracilis and fasciculus cuneatus. Fasciculus gracilis is present throughout the length of the spinal cord because it's going to carry sensation from the lower part of the body, from your coccygeal segment, from the sacral, from the lumbar up to T6. Okay, sensation from all this area. And fasciculus cuneatus is seen in the upper part of the spinal cord, that is above T6. Okay, upper thoracic and then the cervical region. Fasciculus cuneatus, fasciculus gracilis. Okay. Okay, so fasciculus gracilis is medial, fasciculus cuneatus is lateral. Now, what was the question here? Injury to the lateral part, right? So what is there in the lateral part of the dorsal column? The fibers, the axons which are coming from the cervical and the upper thoracic region. So which part of the body will be affected? The upper limb and ipsilateral side. Okay, so the best option here will be proprioception loss on the ipsilateral arm. Easy. Okay, so yes, in our workbook, it has been mentioned. Hope you have gone through it and got it right. Okay, so here also the question and the image which was given, I haven't got it right, but I put both. Okay, so 50-year-old patient. History of fall 1 week before. Complaints of headache and dizziness. And there's a history of chronic alcoholism. And non-contrast CT, what was the image given? Whether this or this. Okay. So in this one, you typically get to see a biconvex, right? A biconvex hematoma outside the dura, between the dura and the periosteum, which we have to go with extradural hemorrhage. And what is the vessel involved here? Middle meningeal vessels. Right? And clinical case scenario, yes, one thing that we should see for is the lucid interval, right? A period of unconsciousness, consciousness, and unconsciousness, yes. And this is extradural hemorrhage. What about subdural hemorrhage that you see here? Beneath the dura, right? Between the dura and the arachnoid, and it is a diffuse one, right? It's very diffuse, clenching on subdural hemorrhage. Okay. And here the patient is alert, conscious, there is no lucid interval, and it's more common in elderly and alcoholism following a trauma, right? Fall. So which was the clinical scenario given and which of the images given? You know better, right? I hope you got it right. So while discussing about middle meningeal artery, extradural hemorrhage, and we have discussed about the biconvex hematoma. Histological image. This one, yeah, there were a lot of confusion over it. Okay, but this also was asked previous years. Okay, so what could this be and what were the options? Glomerulus of kidney, islets of pancreas, Leydig cells or Hassel's corpuscles of the thymus. We'll see few images and then get back to this. So this is the kidney image. You see a darker area above and a paler area below. This is the cortex of the kidney. This is medulla. So what you get to see in the cortex here is a lot of renal corpuscles. Can you make out the renal corpuscles? So that gives a clue that it's the cortex of the kidney. What is there in the cortex of the kidney? The renal corpuscles that consists of the Bowman's capsule and the glomerulus. And all these darker structures that you see will be the PCT, DCT. What you get to see in the medulla will be the loop of Henle and the collecting ducts, yeah, collecting tubules, all that. Okay. Now, okay, so yeah, the answer is the glomerulus of the kidney. And did you have a confusion with the Hassel's corpuscle of thymus? Can you pick out which is thymus here? This is tonsil. You see the tonsillar crypt. You get to see the lymphoid tissue. You get to see the mucus acini. These three features. It is tonsil. And here you get to see the red pulp, the white pulp. This is spleen. And here you see the lymphoid follicles, the sinus, the medullary sinus. This is the histological image of lymph node. And this is the thymus. So thymus, if you see, it is divided into lobules. And each lobule will have a cortex and the medulla is pale staining. In the medulla, you'll get to see this typical whorl appearance, the Hassel's corpuscle. Okay, it's formed by the thymic reticuloepithelial cells. So this doesn't resemble the renal corpuscle, right? What is this? You see darker staining areas and then you see lighter staining areas. Yeah, so this is the pancreas. So in the pancreas, these darker staining areas is the exocrine part, the secretory acini. And here and there scattered, okay, here and there scattered, what you see here will be the islets, the endocrine part of the pancreas. So they are scattered, they are pale staining, and you can see like cords of cells, irregular cells arranged as irregular cords with the blood vessels into which they are going to pour in the secretions, right? So this is the typical feature of islets, and I hope it doesn't resemble the renal corpuscle, right? Yeah. And another option given was the Leydig cells of the testes. So this is the cross sections of the seminiferous tubules. What do you get to see within the seminiferous tubules? Can you see the spermatogenic cells? And these are the Sertoli cells. You'll get to see the spermatids. Now, between the cross section of the seminiferous tubules, can you see the Leydig cells? These are quite large, oval. They have a nice dark nuclei. Nuclei is very typical, large, dark. They occur as clumps. So these are the Leydig cells. So the given image was this, right? So it cannot be the islets of pancreas, which is scattered, cellular, pale staining. It cannot be the Leydig cells found between the cross sections of the seminiferous tubules, large oval cells with the darker, larger nuclei. No. And the Hassel's corpuscles that whirl appearance, onion peel appearance. No. Okay. So we'll go with glomerulus of the kidney. Okay, got it right? Of course, image of this is given in the workbook. Okay. Now coming to the analysis, like out of the 17 questions, majority of it was image-based question. And then next case scenarios and only 3 direct questions. Okay. And of course, all of them were clinically asked. Yeah. And around, yeah, most of them, okay, were repeat questions. Okay. And embryology was covered, image-based questions, histology was covered, upper limb, yes, nerve injuries, right? Upper limb is like, yeah, nerve injuries. We have revised it during our rapid revision before the exam. And lower limb, yes, the lateral cutaneous laparoscopic repair, I put it in lower limb. And fracture neck of fibula. Okay, this time no questions in thorax, maybe I didn't get it. And abdomen, were literally easy, except for that one on the rectal surgery. But if you had known what is erection due to, what is ejaculation due to, you would have got it right, isn't it? And head and neck, of course, head and neck had 5 questions, right? And abdomen, the next important, had 4 questions. The topic is vast and important. Okay, so everything was clinical. Parotid enlargement, tonsillitis, the image-based question on nasopharynx, the clinical scenario on lateral pterygoid, extradural hemorrhage. Okay, all of them very important, repeatedly asked one. Neuroanatomy was literally a easy question. Posterior column, right? Okay, so every topic of this has been covered in ADrPlexus in your classes, right? Either most of them was covered in the 6 a.m. class. I did it for you, and your online classes, and or in the rapid revision. Okay, all of them have been covered. And conceptual, yes, everything has been. ADrPlexus has introduced a concept to you. Okay, and how you had applied it to get your work out your answers, that matters. Okay, the conceptual part has been well provided by ADrPlexus, and everything is there in the workbook also. Yes, guys. Okay, so you've finished your exams, you're just chilling out. As you chill out with a calm mind, prepare your future plans also with positive thoughts, waiting for your positive results. All the very best. Hope you enjoy the session. Give me your feedback. We'll wind up. Thank you.